Hello, everybody, and welcome to Med Safety Exchange for Wednesday, May 28th, 2025. The show will begin in approximately 3 to 4 minutes at 5 minutes after the hour. Good day, everybody, and welcome. My name is Mike Hamilton. I'm Medical Director at ISMP Canada, and welcome to our broadcast studios in Uptown Toronto, I guess, for the spring edition of the Med Safety Exchange. And thank you for joining us today, which is towards the end of May, almost summer. We know that you are busy doing great work, and we really appreciate having you in the audience. And as you seat yourself comfortably, I'm going to call on our Brock University student, Larian, to perform the land acknowledgement.
Thank you. We begin with the land acknowledgement for our office in Toronto, and I encourage you to reflect upon where you work and reside. We acknowledge we are hosted on the lands of the Mississauga of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. This webinar is a production of ISMP Canada and the Canadian Medication Incident Reporting and Prevention System, CMIRPS, with contributions from all of our partners in medication safety and you, the audience. The Med Safety Exchange is presented on the Zoom webinar platform. Audience members are automatically muted and your video is disabled. The presentation part of this webinar is being recorded and will be available on our website in about 2 weeks or so. There are a few ways to make comments or to submit questions. Find the Zoom toolbar typically at the bottom of your screen. The chat panel is open for the broadcast, so feel free to introduce yourself and tell us where you're from. You can also make comments and ask questions via chat. All chat entries will be visible to the audience. If you select the Q&A tool, a window will open. If you have the option to submit anonymously if you wish by checking off the lower box. Responses will appear in the Q&A panel, and questions will only appear in the panel once they are answered. We will try to get to as many questions as we can. There will be an evaluation poll at the end of this session, and we encourage you to provide feedback.
Thank you, Larian. And I just want to say we have, again, a terrific broadcast planned today. First off, we're going to hear from our partners at Canada's Drug Agency for an introduction to who they are and what they do, and a deeper dive into one of their spheres of work. And secondly, we'll hear about some really important work going on in Nova Scotia related to IV fluids. And we'll follow up that with introduction to a new e-learning module that covers some foundational principles of healthcare and patient safety. And time permitting, we'll end with a brief Q&A session. To begin, I've been really privileged to be able to present and discuss all things medication safety with international experts and organizations. And I've always been struck by the very high regard that Canadian organizations have in the eyes of the world. And I'm therefore very excited to welcome our first presenter to tell us about sort of a new organization that's coming to fore, Canada's Drug Agency. So allow me to hand over slide control. And please, Jonathan, go ahead.
Perfect. Well, thank you very much, Dr. Hamilton, and thank you to ISMP Canada for having me here today. And I was just noting on the webinar chat, great to see folks from all across Canada, as well as I think we had, I saw someone from UAE and England, international folks calling in as well. And I did see a couple go Edmonton go, so go Oilers. Before I start, just want to acknowledge that I am working here in my Toronto home office. So I'm speaking with you today from the traditional territory of many nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. I'd also like to acknowledge that Toronto is covered by Treaty 13 of the Mississauga, the Credit. So I think I have controlled the slides. There you go. So again, I'm Jonathan Lam. I'm the director for appropriate use, a relatively new area within Canada's Drug Agency. So my kind of goal today, I think, are twofold. Like Mike said, to really kind of give a little introduction about Canada's Drug Agency and who we are. And some of you may have heard of us from our previous name, CADITH, before. So I'll tell a little bit about that history. My second objective is to delve a little bit deeper into my kind of area of work within CDA AMC, which is the appropriate use program. So like to highlight our strategy work that we've been working on, and also actually some exciting work we're collaborating with INCP Canada on around polypharmacy. So just some disclosure and understanding of our organization. So we are funded by contributions of both federal, provincial, and territorial ministries of health of all across Canada. We do receive application fees from pharma industry, specifically for our reimbursement review processes for oncology, non-oncology drugs, and also for scientific advice as well. So who are we? Despite our name, Canada's Drug Agency, we're actually not, in a legal sense of word, agency. We are a pan-Canadian health organization. We're independent and not-for-profit. While we're created and funded by, like I said before, federal, provincial, and territorial governments, and led by a 13-member board, and we are a nonprofit, not an actual kind of agency in that word, like I said. So, what do we do at a high level? So we provide evidence and advice to health system leaders so they can make informed decisions about these three main areas. So on drugs. So for instance, whether or we make recommendations on whether drugs should be listed on public drug formularies, on health technology, as well as we provide evidence for health systems issues as well. So I think at the beginning I was mentioning we are previously known as CADIT. So I just wanted to tell a little bit of a journey of how Canada's drug agency came to be. So in 2019's budget for health from the federal government, there was $35 million that were committed to establishing what was called a Canadian Drug Agency Transition Office. And they were really tasked to inform a mandate on what a Canadian drug agency could look like to support system coordination and other activities within the pharmaceutical area. Throughout 2021, the CDATO, so the Canadian Drug Agency Transition Office, did wide-ranging consultation to identify what the gaps are and also what the opportunities are in the pharmaceutical systems. And you can note there, this included over 400 meetings with 13 provinces and territories to really understand what are the gaps, what can be done with Canada's drug agency. In 2023, so a couple years ago in December, the government announced Canada's drug agency will be built on a CADIT, which some of you may know, with an investment. And Canada's drug agency was then officially launched in September of 2024. So while we're relatively new as an organization, there's a lot of history behind it within CADIT in our work in health technology assessments. So what are some of the new emerging areas of work and why kind of Canada's drug agency? On the next slide here, with the announcement, I guess, and creation of Canada's drug agency, there are three new functions that were brought into the fold. I'll touch on appropriate use last, but wanted to highlight, along with appropriate use, we were tasked with supporting data analytics. So providing pharmaceutical data and drug data analytics to really have that ecosystem and system-wide focus to help provide insights into patient and health system outcomes. The other function is system coordination and alignment, so enhancing drug system efficiency and coordination by creating a better connected pharmaceutical system. I'll speak more about the appropriate use function in the next one, but really at a high level. It's about improving the appropriate prescribing and use of medications for better health, better patient health, and to support system sustainability. So I know probably a lot of this is very near and dear to your hearts of those who are joining this webinar today. So for the next few slides, I'll be talking specifically about the appropriate use program at CDAMC and also about the development of our strategy. So what is appropriate use? I feel like this group would know this very well. We did actually spend quite a bit of time finessing on this definition that we have in front of you to really have it so it's something that's positive and focused on patients. I will read the specific one out loud. So appropriate use is when patients, caregivers, and healthcare professionals work together to choose safe and effective medications most suited for that person's needs, goals, and to achieve best health outcomes. So really kind of pointing to that shared decision making and the selection of safe and effective medications. And I think another kind of important piece here is around the needs and goals of the patient. I have some kind of definition below on what inappropriate use could be, just as some examples to help understand. So probably this group would know like overuse of medications, like for instance, antipsychotics for anxiety and dementia without a psychosis diagnosis. There could be underuse of medications as well. So if SANs are not used for persons at higher risk of cardiovascular disease. And there's a broad term inappropriate use. So an example here is really kind of the prolonged use of antibiotics, longer than the recommended duration. This again will not be a surprise to anyone in this group, but why is appropriate use a problem? We know that the prescribing and use of medications across Canada continues to increase, and suboptimal use and prescribing of medications could have significant negative impacts. So 55% of adults and about a quarter of children take at least one prescription medication at any given time. We also know that there are 1.9 million seniors in Canada that regularly use at least one inappropriate medication, and that's defined by the Beers criteria. And about 1 in 5 adults between the ages of 40 and 79 take five or more medications or polypharmacy. Uh, as we know, like there are reasons why people can be taking five or more medications. That's totally legitimate and appropriate, but there could also be problematic polypharmacy, such as prescribing cascades and drug interactions for folks as well. So kind of going on laying kind of the groundwork for why appropriate use is important. There's also actually a number of excellent programs and initiatives, so ISMP Canada being one of these, that are doing great work across Canada now in supporting the better use and prescribing of prescription medications. But there's limited coordination across these groups. So a lot of our strategy, as we kind of go through, we'll see, is how do we bring these groups together? How do we connect these different kind of disparate pieces? And how do we support these groups and working together and rowing in the same direction for larger collective impact? So this slide is a little dense, but I did want to go through a little bit on how did we develop our strategy. Um, Earlier, I mentioned the Canadian Drug Agency's Transition Office. With that work, they did produce a final report on appropriate use. And really, that was recommendations to CDAs on what we should be doing, what our strategy could look like, and what our program could look like on appropriate use. So that was really a foundational element that we used when we were developing our strategy. As I mentioned, they did have a broad consultation during that time on the final report as well. So that took the period of 2023 to 2024. Really, since the end of last year, I'd say around September, October of 2024 until now, we have been finalizing the strategy. So we have been speaking with folks around kind of specific strategic priorities and specific actions that we should be taking from it with input from interested parties. So this final strategy will really guide Canada's Drug Agency work in the appropriate use space for the next 5 years. This is our advisory committee, so the Appropriate Use Advisory Committee of Canada's Drug Agency, and they have been instrumental in really lending their input, advice, and expertise in shaping our strategy as well. So these folks have expertise in appropriate use, healthcare and pharmaceutical policy, as well as we have patient voices in there and prescribers, pharmacists, and nurses in this group. So they really kind of guided a lot of this work as we finalized our strategy. So just at a glance, I talked about getting input from interested parties. So we had 100% of provincial territorial representation. Quebec was not specifically part of the focus groups, but Ines from Quebec did participate in our town hall. We had 11 sessions, so 10 focus groups and one town hall where it was an open registration. And through all these different sessions, we had approximately 235 participants who were able to provide input into the strategy. And just a little bit on who we engaged with. Like I said, we had federal, provincial, territorial governments represented. We also had a small sample, I'd say, of Indigenous healthcare providers, including members of the Indigenous Pharmacy Professionals of Canada, who we engaged with as well, and we'll continue to have those discussions. And as I said, patient caregivers, equity deserving populations, and other health system partners. So finally, what is kind of our appropriate strategy and what is it about? So here's at a high level what it is. It is a 5-year plan for CDA to help improve the appropriate use of prescription medications across Canada. while this is going to be led by Canada's Drug Agency, it will actually be implemented through a collaboration with partners. As you heard from me in the beginning, there are many programs out there doing this work already. So we know that while we're leading the strategy, we cannot get this done without collaboration and really working closely with all these partners, again, including ISMP Canada. Our strategy is a person-centered and really promotes shared decision makings between patients, caregivers, and the healthcare providers. And it's about also increasing access to evidence-informed tools and resources that can support both patients and caregivers in making the best decision possible about their medication. I also wanted just to highlight what this is not about. So this is not a cost driven by cost containment. This is not a policy or guideline document that's going to go into specific individual drugs and what is appropriate and what is not. It's really about providing tools and resources to, again, patients, caregivers, and healthcare providers on supporting their decision making. So here are the 4 strategic priorities of the strategy. And this won't be a surprise after kind of a little bit of our description of why the strategy is needed. One part of it is really the strategic priorities is connect. So really advancing appropriate use of medications by building relationships, by mutually enforcing activities. The second is partnerships and program development. So identify partners and programs out there that we would want to work with to advance for greater impact. There's a strategy and policy piece. So obviously delivering the strategy itself is one, but then also what is the plan of action for us to support decision and policymakers. And then there's evaluation and reporting. So really looking into how do we tell our story, making sure that we're making impact. So I'm seeing a chat around AMC. AMC is the French abbreviation for Canada's Drug Agency. So here's just a quick next steps. I've talked about kind of the winter and spring. We've been finalizing the strategy. Right now, we are working to submit the strategy into Health Canada. The final step of publication is actually up to Health Canada to publish it. Our work in this space is to provide this report into Health Canada. And that's why today, all the kind of headers, the slides are still draft because we are submitting this for Health Canada for publication. So in the next, hopefully I'm doing okay in timeout. In the next few slides, and let me know if I need to speak a little quicker. I just wanted to highlight some work that we're already doing. So while we've been spending the last few months working on the strategy, we're also very cognizant of the fact that we didn't want to spend our first year as a program just working on a strategy. So there are a number of projects and initiatives that we're taking on already. So one I wanted to highlight, and this speaks to a lot of that connection piece that we talked about, is the Appropriate Use Coalition. So this is a grassroots group of 11 organizations of quality, safety, and health system and patient partners that are involved in addressing appropriate use, and they're committed to supporting this work. And again, you'll see ISMP Canada in here, for instance. You also see Choosing Wisely Canada, the Canadian Medication Appropriateness and Deprescribing Network, and probably a few others that you've be quite knowledgeable about. But really the purpose of this is supporting this work. So partners are working together to take collective action to reach a broader impact. So one kind of body of work that's been ongoing is on the improvement of antipsychotic use in long-term care homes. So I don't think I have a slide here, but maybe I can put it in the comment later. There will be a webinar announcing actually a national target for appropriate use of antipsychotics in long-term care in June. And it would be great if others would want to join and listen in on that. So that's exciting work. And CDA's role in this is to provide a secretariat support. This group is co-chaired actually by Choosing Wisely Canada and the Canadian Medication Appropriateness and Deprescribing Network. So this is just a highlight of some work that came out from the coalition already, really highlighting the fact that there is a variation across Canada in the use of or potentially inappropriate use of antipsychotics in long-term care across the provinces, and really some of the impetus for this work. The data is not shown here, but the use of potentially inappropriate use of antipsychotics has actually been improving until the point of the pandemic, where it was around 19%. And since the pandemic, in the most recent data that I have seen, has gone back up to about 24.5%. So really, what are some work collectively that we can do to start improving that? Oh, I think I have two more slides. So here is the appropriate use program map. Again, I spoke to, and I'm probably just kind of repeating now, that there are many programs out here. So this is an interactive program map, and there's a little QR code there for those that are interested. It really kind of provides then from across to Canada, what are some other initiatives on appropriate use that are out there. So if you go to that, like, you can sort it by various types of initiatives, so audit and feedback, or academic detailing, or clinical decision aids, and you can see where these different programs are at. And really the purpose is to support awareness of these programs. And one thing we heard is sometimes people don't know about these programs. So how, even if you're working in BC, Ontario, similar things. So this is time to try to build some of these connections there. On the map, if you have a program that's not actually on the appropriate use program app now, there's a little form that you can fill out, so we can add it. Really, this is not a static document. We're looking to build this over time to add other programs in there as we continue. And finally, I'll be remiss not to mention the exciting work that we're doing with ISCP Canada, as well as another organization called deprescribe.org. And this is a polypharmacy awareness signature project. So based on the great success of the 5 questions about your medications that ISCP Canada has done in the past, we have worked together to, what are 5 questions to ask about my multiple medications? So building awareness about, if you are taking multiple medications, what could that look like? And this is still a draft on it. It has changed a little bit since then, but we're looking forward to kind of finalizing this, and probably, hopefully, coming back another time at the exchange to share more about this. And with that, maybe I'll end with a couple kind of maybe a little bit self-promotional piece about folks who want to stay in touch with work that Canada's Drug Agency, including some of the updates I've given today. Here's the QR code for folks to kind of subscribe to the dispatch. And lastly, we're always seeking, and this is not specifically about appropriate use, but our other health technology assessment work, we're always seeking to identify and select clinical experts based on these different criteria to participate on different panels. So if you have any questions or want to participate or have inquiries about becoming a clinical expert, please feel free to email requests at cta-amc.ca. And with that, I think that's the end. I understand I'll take questions at the end if there's time, so I'll pass it back to Mike.
Thank you very much, Jonathan. Great overview of what you've been doing, and it sounds like there's lots of opportunity to get involved. And there, as you mentioned, there are lots of great programs going on across the great country of Canada, and it's really important that somebody takes the lead in bringing these people together and connecting and networking, and I'm glad that's part of the mandate of the CDA. So we'll move on to safe storage of IV fluids, and it's known that IV fluids cause patient harm, and ICP Canada, we regularly receive incident reports proving as much. There are many reasons behind the errors that lead to harm, and we're very grateful to our next presenter for telling us of a project examining some of the really important underlying contributing factors. So I will pass control to you, and I'm hopeful that that works for you.
All right. Thank you very much. Can you hear me okay?
You're right on, Nancy.
Okay, perfect. Make sure we can advance the slides. Hello, everyone. Thank you for the opportunity to share our CQI project, standardizing the IV fluid storage to minimize selection errors. I'm a nurse educator with the technology-enabled practice team at Nova Scotia Health. We are a small team of nurses and pharmacists focused on integrating new technology into clinical practice. There we go. Our project was featured in a 2024 ISMP Canada Safety Bulletin, along with a supplement focused on improving IV fluid labeling. Today, I'm going to walk you through how the project started, highlight some key findings, and outline our next steps. Since the launch of our smart pumps in 2021, our technology-enabled practice team has actively monitored infusion practices across Nova Scotia Health using various CQI methods. We collaborate with various groups like oncology, palliative care, and home care, and regularly review CQI data, which we share on our infusion therapy website. 6 months after the implementation of our smart pumps, we conducted a provincial assessment to evaluate infusion practices and identify ongoing challenges. This prompted a review of infusion-related incident reports to monitor common errors such as incorrect line setup and programming. In the fall of 2022, our team reviewed 18 months of Safety Incident Management System, or SIMS reports, and identified a pattern of errors involving large volume parental fluids. For this presentation, large volume parental fluids, or IV fluids, involves any plain or potassium mixtures involving Ringer's lactate, normal saline, and any dextrose formulations. IV fluids ranked among the top 3 drug categories involved in medication errors. From April 2021 to September 2022, incorrect selection or administration of 13 different IV fluids appeared in 4.8% of infusion-related SIMS reports. While most were no harm events, just 69%, 19% caused mild harm and 4% resulted in moderate harm. Near miss events involving IV fluids accounted for near 8% of the reports. Given that up to 90% of inpatients and ambulatory patients receive IV therapy and parental administration carries a 3-fold risk of harm or death, IV fluids remain a significant yet often overlooked patient safety concern. As a nurse, these findings sparked my curiosity, and I wanted to find out more to why this was happening. So the goal of our project was to evaluate the labeling and storage practices of large volume parental fluids in clinical areas, identify the most commonly used parental fluids, and examine processes that potentially contributed to IV fluid selection errors. Our team of 6 nurses and pharmacists visited 15 community, regional, and tertiary care facilities across the province between March and April 2023. Data was collected from approximately 150 care areas that administered infusion therapy. Interviews were conducted with 1 or 2 available nurses and/or the ward aides on the process of IV fluid storage and selection in clinical areas. Non-clinical audits of the common types of IV solutions available in care areas were recorded, as well as how the IV fluid was stocked, labeled, replenished, and returned. The volume and type of expired fluid was also observed. We identified 4 key factors contributing to the IV fluid selection errors. The first was storage organization. Disorganized systems make it harder for staff to quickly find the correct fluid, increasing the error risk. Second was labeling discrepancies. Inconsistent or unclear labels create confusion and lead to selection mistakes. The third was oversupply and expired fluids in stock. Expired fluids stored with active stock raise the chances of administering outdated products. And finally, the ordering processes. We noted that gaps in knowledge about ordering and returning fluids can lead to overstocking, increasing selection and expiry risks. Each of these factors can compromise patient safety, potentially leading to adverse outcomes, longer hospital stays, and higher healthcare costs. I'm going to take you through each of these findings with some pictures so you can, hopefully it'll resonate with you. So the first was storage. So IV fluids were mainly stored in unit storerooms or medication rooms, with smaller quantities found in procedure carts and other areas. Most storerooms used a basic organization, meaning the same fluids for all fluid types and sizes. As we can see here in this picture, all of the bins are red. Bins were often overfilled, causing overflow into the adjacent bins. And we can see this in the top shelf of the picture, where we see that there is IV bags kind of stored on top of one another, and they are toppling into each other's bins. Some storage areas were also noted to be quite warm. In smaller spaces, dividers were used to separate similar fluids, such as normal saline and half normal saline. You would find these in the same color bin, and with just like a cardboard or a piece of plastic dividing the two. So taking one bin and almost creating two storage areas within it. But these bins also were often too overfilled or unbalanced, which caused the bags to mix. So one type of fluid, so if we were looking at normal saline and half normal saline, the normal saline would be used far more often than the half normal saline, and so the half normal saline would fall into the normal saline side. So this may help explain why nearly half of the staff, to 48%, reported finding the wrong fluid in the bins. Label styles varied across the province. Areas stocked by ward aides often used handwritten or label maker labels, as seen in the top picture. Zones that were managed by stores and materials staff used printed barcodes, barcode labels, and or tags. In many cases, the fluid in the bins did not match the label, increasing the risk of a selection error. The bottom picture shows that there's potassium fluid bags where a dantrolene kit should be. We were surprised by the volume of IV fluids in some areas. Some storerooms had entire walls of stock. Staff in these areas said that they were the go-to unit, carrying all the fluid types for the facility. This also included the rarely used fluids, such as Ringer's lactate with 40 of potassium, or a 2/3 and a 1/3 with potassium. And these fluid types, may not be even used in that particular area, but because they had the largest storeroom, they were designated as the go-to unit, and we had to have those fluids just in case. We also found a significant amount of expired fluid mixed with active stock. As you can see in the picture, the bag's expiry dates are July 2021 and September 2022. If we remember that we visited the sites in March and April of 2023, which means these bags were about 1 to 2 years past their expiry date, and they were actually positioned at the very back of the bin, with lots of the proper fluids that were within their expiry dates at the very beginning of the bin. Sterile water also appeared in various areas, and all of the bags looked identical: inhalation, injection, and irrigation. Which posed a real potential selection risk, especially when they were found in with the rest of the IV fluids. When we talked about process, we noticed that ward aides reported challenges using the online catalog to order IV fluids, sometimes selecting the wrong product. In one zone, nurses had to order the fluids using the JB number that was on the label, on the printed barcode label, and not by the fluid name. Communication to stores clerks or ward aides often relied on handwritten notes, post-its, or whiteboards. There was confusion over who was responsible for rotating the stock. Both materials management and nursing thought it was the other's role. We also found limited awareness of how to return unused IV fluids. A common response was that unused boxes would just sit in a corner until they expired and get tossed. Stores also sometimes moved these fluids to other units that could use them. Mini bags were often found unwrapped in medication rooms or carts as a time-saving measure for nurses. However, reported durations for how long they have been out of the packaging varied widely. Some would say that, oh no, we go through them quite quickly, they're only there for less than a day. To others, they had no idea how long they had actually been there in the drawer. So this is a drawer in a med room, which was a common sight in many of the areas, and it may be familiar for some of your areas as well. So we have here a mix of the different sizes of the mini bags. So we have 50 ml bags and 100 ml bags. We also have a mixture of the types of fluids. So there are saline and dextrose in here. They're all mixed together. We also have 2 different types of mini bags, meaning that we have regular, and then we also have like a mini bag plus to be able to add, to reconstitute like a vial that you can just puncture onto the bag. So I'm going to throw out my question to you that says, how many mini bags are in this drawer? So if you want to have a guess, you can throw your guesses into the chat, and I will answer at the end to see if anybody got close. The bigger question I had when I saw this is, how long have they been there? And this particular med room was very warm. And how do we know if these mini bags have been rotated? How many mini bags are actually used in a 24-hour period in this particular unit that warrants to have this many mini bags open, in this particular drawer? And as a note, when we've gone, and you'll hear about this in a little bit, when we've gone around to do another audit, we've actually found drawers that actually had more than this particular drawer, more mini bags than the one in this picture. And if you look closely enough, you'll see a mix of the different styles as well as the expiry dates. So we had a mixture of December 2023, October 2023, March 2024, and January 2024. So a very wide variety of mini bags in this drawer. So with these results in mind, I will share our next steps to be able to move this initiative forward. So first, we're going to go back and revisit the SIMS data to assess the trends in infusion errors since we started smart pump implementation in 2021. And this will help us better target interventions. So if we have a look at the chart, what we have here is that we show a slight increase in IV fluid related errors, which is the left-hand column, from 2021 to 2023. We're slowly seeing an increase. Notably, the most common issue was selecting the wrong product. So if you see on the right-hand column, and so what we mean by the wrong product is that the order was to infuse Ringer's lactate. When the nurse went in to change the bag or to hang a new bag, normal saline was found. Perhaps the order was for D5.5 normal saline, and when she went in to change the bag, he found that it was a D5 normal saline. So it was the wrong product. So that was the most common issue, and we see that there's a 2-fold increase in that in 2022 as well as 2023. So we have pulled the 2024 data, and our plan this summer is to begin analysis of that so we can further track our infusion trends. Next, we're partnering with materials management on a small project in 2 facilities to review IV fluid stock lists and storeroom organization. We are starting by examining the existing closet lists, which learned that those are only reviewed every 2 years. We'll also be looking at the ordering frequency from the units and see how they match up to the closet lists, as well as auditing their current stock. Because I think what we saw is that what was on the closet list, there was way more in the storeroom than what was actually on the closet list. We will compare all of this data against the common order sets that are used in each of their areas in hopes of developing a more standardized closet list. As you can see in this picture here, that's a lot of fluid. And this is only one snapshot. You're missing, there's pretty much, if we added another picture and a half, you would have seen the whole wall of IV fluids, and there was pretty much every fluid that you could order was on this wall. Our site visits focused on 4 ISMP recommendations from the report, such as sterile water, separation of the IV solutions, if there was any potential for return locations, as well as how the bins were labeled. Results from this project with materials management may help support the development of a parental practices committee. It was a very valuable learning experience for both myself for nursing as well as materials management, because we were able to highlight how the stocking and organization can contribute to selection errors. So while from a nursing perspective, we organized our storeroom to make it easier for us, but it doesn't make it easier for materials management. As well as when we're looking at the sterile water, for example, the sterile water the bags look exactly like IV fluids. So materials management places it with the rest of the IV bags because that's how they're ordered and that's how they're actually stocked in their warehouse where they keep it. But as well as the bins where they keep them, because they need a heavier duty rack to be able to hold them. Unfortunately, when you put sterile water with the rest of the IV fluids, there's a high risk of it being inadvertently grabbed and infused. And so those type of things should be placed with respiratory therapy or with wound care supplies. And so that was eye-opening for materials management. They didn't realize that. So it was a good opportunity to work together. Third, we're advocating for a parental practices committee so we can promote safe practices by establishing policies ensuring the safe administration of parental medications. We're going to enhance clinical competence through the development of a comprehensive program supporting skills across all parental practices. The third, we wish to drive practice improvement by leading organization-wide standardization, performance measurement, and quality improvement in parental care. And finally, we wish to explore the role of fluid stewardship, which is a clinical practice framework focused on the appropriate, safe, and effective use of intravenous fluids in patient care. Similar to antimicrobial stewardship, fluid stewardship aims to optimize fluid management to improve outcomes and reduce harm. So this project has certainly raised more questions for our team, but one thing is absolutely clear, that improving the safety of infusion therapy starts with how it is stored. It is essential that we begin this conversation wherever infusion therapy is happening. And I leave you with a few questions, still burning questions that are guiding us for the rest of the projects that we want to do with this particular project. And that concludes my presentation. Thank you very much for joining me. And if you have any questions, please add them in the Q&A or the chat box, and I will do my best to answer them. And there was 66 mini bags in that drawer. So thank you so much.
Thank you so much for taking us through that work. It's amazing the response that the pictures got. And I think it really hammers home how underappreciated the storage aspect of these IV fluids is. And I found the continuing conversation slide particularly intriguing. I think it really emphasizes that the more you look at an issue, the more questions arise and the more opportunities, the more you learn how complicated and how complex this whole enterprise is. So thanks very much. And now we'll turn the next few minutes over to updates from the ISMP Canada team. And I'll start by quoting James Reason related to just culture. And he defined it as an atmosphere of trust in which people are encouraged, even rewarded for providing essential safety-related information, but also one in which it's clear about where the line must be drawn between acceptable and unacceptable behavior. And I think we all have a sense of what just culture is, really, but we're often challenged to understand it and put it into practice. And so we'd like to introduce a new e-learning module called Just Culture Essentials. And this is complimentary, meaning free. It's about 20-minute long e-learning module developed by ISMP Canada and the Health Quality Council of Alberta. And it helps to explain what exactly is just culture, how can just culture and safety culture work together, and considerations for improving safety culture in your own organization. And it's really intended for any healthcare professional, staff, leaders, even patients, families, and caregivers. And access to the module is on our website or through the QR codes visible on your screen. So I encourage you all to look at it and see how it fits into your own practice. And I'd also like to highlight our next session of the Canadian Medication Safety Network. This provides a chance to hear from healthcare practitioners, from patients, from families, from caregivers about what they're thinking in medication safety, what's new, what's an issue that we need to address. And we've had some really good discussions at previous episodes from around the country. This upcoming one on June 11th is related to long-term care, but there are a lot of issues in long-term care that have that resonate throughout all our sectors and throughout everything we do. So I encourage you to sign up using the QR code and drop by for some really great interactive discussion. And for the next few minutes, we do have a couple minutes. I'd invite Jonathan and Nancy to come back, and we'll go through a few questions that arose in the chat box and the Q&A panel. So, Jonathan, are you there?
Yes, I am. Sorry, I was muted.
No problem. So I just want to open up a couple questions from the audience that we've had. One is about the former CADIF. So I use the CADIF materials about technology and medications quite frequently over the years. Are those materials still going to be available, and will that type of work continue?
Yes, definitely. The work that for appropriate use, data analytics, and system coordination I spoke about, those are new emerging area of focus of work. All our current work that we've always done in terms of evidence reviews, making recommendations on drugs, on health technologies and health systems, those all continue. This is additional work that we're doing, and you'll be able to find all that work at cda-amc.ca.
Great. And the second question for you, and you may not have a full answer, but it's an interesting question. Related to disparities across jurisdictions with respect to medication insurance coverage, with programming, particularly as some of the more expensive medicines come along, or the differences in biosimilars, medication-related services like pharmacogenomic testing. There's wide variances across Canada. Does the CDA have a role in their coordination and alignment function to bring all of this together to work on equity across the nation?
Yeah, that's an excellent question. I think you're right. I don't know if I have a full answer for that. I think I can say that inclusion, diversity, equity, and accessibility are a key principle in all the work that we do here at CDA. Maybe what I can do is I can take this question back around to my colleague at Health System Coordination on exact this. Mike, maybe if you can fire this over to me, and I'm happy to kind of share that. But again, I think equity is something that we think about and care about deeply.
Thanks. Thank you, Jonathan. Nancy, a couple questions for you.
Sure.
Really interesting presentation, and this person worked in another country where IV fluids are considered a true medication and were under the purview and control of pharmacy. So they were stocked in ADCs or in well-organized cabinets, and they comment it just seemed to be safer, more systematic, more logical, and wondering if you have any thoughts on moving IV fluids from central stores or materials into the pharmacy.
Yes. So my nursing practice has led me down. I worked down in the States as well as over in the UK. And in the US, because it was a private system and for billing, we did keep all of our supplies, including IV fluids, in an ADC, that's where we would go to remove the medication. So it would be tracked. Over in the UK, you needed to have a second person. It was treated as a true medication. Over there, where I had to have, before I could hang any IV fluid, including just a bag of normal saline, I required a second person. It was always an independent double check. For here in Canada, or at least I can only speak to here in Nova Scotia, it's not. So so this is where we've kind of, the gap is getting bigger, the knowledge gap, because the more we dig, the more we're finding is that when the orders are faxed to pharmacy, so pharmacy will review all of the orders, but not the IV fluids. And so it really relies on the physician to order the correct fluid, and the nurses will hang whatever they say, but nobody's like kind of doing a double check on the order to make sure that it's correct or the rate is correct, which kind of really, that's another question, kind of that we're going to be looking into and why is that?
So a second question, and probably somewhat related, is that pharmacists and nurses typically play a very limited part in the logistics of stocking and storing IV fluids. And I think they could easily dismiss this work, saying it's really not my job. So how do you get them on board, or what's been in your experience about the response and enthusiasm by nurses and pharmacists?
Well, that's a good question. So it all started with when we had done our infusion practices assessment, we were noticing some strange, some suboptimal practices. And that's when we're like, we weren't seeing, in particular, the incorrect line setup. So we weren't really seeing those incident reports going down. So that's when we're like, well, let's do a deeper dive. And that's what kind of led us to, let's go have a look at the storerooms, because, why are we doing that? But at the same time, we were also seeing incidents with high alert medications. And so that grabbed our attention of our pharmacist team members. You say, well, why are we having so many incidents with, say, norepinephrine, for example? So, and then it's just kind of snowballed from there. And we got materials management on board, and they're like, we never really looked at our storeroom, when they come up to stock it, we've never really looked at it that way before. So it's really, we're kind of uncovering all of these stones as we go. And we were just recently, kind of learned about a kind of a fluid stewardship, kind of role. We know that that's in place. I think it was over in the UK, as I watched a video on, and loved it. So that's why we're really hoping to gain momentum, kind of with this, just by using data that everybody has. So everybody could do this, kind of in their own area if they have access to their, SIMS, their incident reports. So we could get a movement started here. Let's take infusion therapy back. So make it safer.
Yeah, tremendous work, and I really look forward to learning more. So thank you. So as we wrap up, I want to thank Jonathan and Nancy and everyone who contributed today. Terrific learning, lots of important things going to happen in the future as well with respect to CDA, and very interesting ongoing work in Nova Scotia related to fluids. And we'd also like to thank you, the audience. Terrific chat today and Q&A. Please fill out the evaluation form, evaluation poll, and let us know if there's anything you'd like to see or things we could change. And importantly, we learn from stories, we learn from conversations about errors, we learn from you. If you have anything to contribute, please reach out to ISMP Canada, reach out to us and be part of this. A reminder that the link to the recording will be available in a few weeks or so, and along with any links to websites or materials. And we look forward to welcoming you back for our World Patient Safety Day webinar in September. So we will see you towards the fall. Enjoy your summer. Continue your great work, and please help us make this better by contributing. Thank you.